Hello, everybody, and thank you, James. So I'd also like to welcome you to the White House. I'm so pleased to be joined by Dr. Howard Koh, who you know is our nation's Assistant Secretary for Health. You know, his office and his partnership with us and his whole team are really critical to our efforts to implement this strategy. So I'm really happy to share the stage with him today. So I'd also like to acknowledge our colleagues at the Office of Management and Budget. You know, we work very closely with them, and the Health Division under the leadership of Keith Fontenot are really critical to all of us getting our work done, so I'd like to thank them. So we would like to talk to you today about the continued steps we're taking to implement the National AIDS Strategy. So as you know, one of the main goals was to really refocus our existing efforts and deliver better results to the American people with existing resources, but also make the case for new investments. And so today we're excited to share with you some of the progress we've made in really a few short months since we released the strategy. Now, last July, when we released this strategy, the President issued a presidential memorandum, and he directed 6 lead agencies: Health and Human Services, Housing and Urban Development, the Department of Justice, Department of Labor, the Social Security Administration, and the Department of Veterans Affairs to submit agency operational plans for implementing the strategy. He also directed the Department of Defense, the Equal Employment Opportunity Commission, and the Department of State to provide recommendations for implementing the strategy. Now, these federal agencies, quite frankly, have shown a remarkable commitment to this work. Now, we have several of them here. Can I ask just all the federal employees who are here with us to stand? And can you join me in acknowledging their important work? Thank you for all that you're doing. So now today we're releasing the plans developed by the agencies as well as an overview report that we produced to demonstrate the synergies that can be achieved by having different agencies work towards shared goals. And so as James mentioned, these can be accessed at www.aids.gov. Now, there's so many new and important activities that the agencies have committed to undertaking. There's no way I could effectively summarize them now. So I would like to, however, give you a flavor of just a few things that are in them. Now, since we will be hearing from Dr. Koh, and since HHS has such a big role in all this, I'm going to let him talk about what HHS is doing. But I would like to highlight some of the key activities of some of the other federal agencies. So in order to ensure that our federal investments are being fairly allocated in using the latest data about the HIV epidemic, HUD is working on a legislative proposal to update its formula for allocating funding through the Housing Opportunities for People with AIDS Act program, or the HOPWA program, to rely on living HIV/AIDS cases. They're also improving housing and service integration and working with other federal HIV programs by identifying models of coordinated service delivery. They're also working to expand the use of their homeless management information system client-level data. So HUD and SAMHSA already use these data, but they're working with VA as an example to also begin using these data. Now, the VA is stepping up its efforts to ensure that all veterans are tested for HIV at least once in their lifetime, with a focus on the high-risk populations identified by the strategy. Part of this work is also focused on training providers. So we know that primary care providers, women's health providers, mental health providers, substance use providers, and others are better equipped to offer routine screening for HIV. The DOJ is taking proactive steps to enforce the law and investigate allegations of HIV discrimination as priority investigations. Additionally, the Bureau of Prisons, which is part of DOJ, is taking a number of steps, but it, along with the VA and HHS, are all planning new activities to improve community reentry for people living with HIV who are leaving correctional institutions. DOL and the EEOC are both taking important steps to enforce civil rights laws that protect people living with HIV from discrimination in employment. And in fact, the EEOC reports just that already in the first quarter of this year, that they settled 3 lawsuits concerning HIV-related discrimination, and they filed another suit for another individual who's experienced such discrimination. Now, SSA is planning to take a number of steps to be more inclusive of people living with HIV in their programs for people with disabilities, but they're also currently working on updating their medical listings for HIV. Now, these are used to expedite an assessment of disability when individuals first apply for Social Security benefits. And they update these listings for all conditions on a periodic basis, but this is especially important for conditions like HIV where there are evolving clinical manifestations. We want to make sure that the listings they're using are based on our current situation. And then finally, the Office of the Global AIDS Coordinator at the Department of State is offering a number of recommendations to improve our domestic program based on the experience with PEPFAR. So in just one example is that they're going to share data from mathematical modeling activities and demonstration projects investigating successful combination prevention methods. And we think this is just the type of way that we should be trying to learn from our global AIDS program. So while the context might be different in the United States and other parts of the world, in both places we're grappling with the same issues about how do we put together the tools we have for HIV prevention and get the best results. So we should be looking outside of our borders for how we can improve what we're doing inside our borders. Now, I recognize with these brief comments that I probably raised several questions, and I've only touched on some of the top-line issues. So I encourage you, again, to go to www.aids.gov and read about the agency plans. Do you remember the website yet? I'll try to stop. So now, we've really come a long way since the beginning of this administration. 2009 for us was really focused on gathering public input and convening our federal experts to develop the strategy. Last year, we developed this strategy, released it, we began implementation activities, including the development of the operational plans. So over the coming year, as you'll see from these agency plans, the agencies have their work cut out for them in delivering on all the things they promised. So they're going to be busy. But I wanted to let you know what ONAP's focus will be. And we'll continue to convene our interagency working group to coordinate the administration's HIV policies. The President directed me to report to him annually on our progress in implementing the strategy. And we're just beginning to have conversations with OMB and our other federal partners to think about a good model for reporting on our annual progress on the national strategy. So again, it's not about reporting what the federal government's doing, but what are we doing as a nation to really implement the strategy effectively. Now, the strategy includes targets to be achieved over 5 years, and we'll also work with our federal partners on a limited number of process measures that will help track agency progress from year to year. And just as when we released the federal implementation plan, it gave very specific action steps agencies would take in 2010 and 2011. We promised to update that on an annual basis, so we'll start and think about new activities for 2012. Now, I'll say that we'll continue to challenge ourselves in being both specific in the commitments we make, but also strategic. So I think we also need to be clear that that means not committing to every good idea, but really saying, what are the things that are going to have the biggest impact, and what are the number of things that we can actually do? So it's not just about promising more, but what are the things that we really have the capacity to do and will have a big impact? Now, finally, I know many of you are looking for us to demonstrate new levels of collaboration and coordination across federal agencies. I actually believe we've practically moved mountains in this regard since we've put out the strategy. And I urge you to read the overview report because it talks about just some of the steps the agencies are taking. I also know that Dr. Koh personally and his office have invested in a lot of activities in this regard, and he'll be speaking a little more about that. So I think that's something that's very exciting. Now, everything I've been telling you about has really been focused on the efforts of the federal agencies to implement the strategy. But as we say in the strategy itself, implementing it does not fall to the federal government alone, nor should it. Our success will require the commitments of all parts of society, including state, tribal, and local governments, businesses, faith communities, philanthropy, the scientific and medical communities, educational institutions, people living with HIV, and others. So ONAP and the individual agencies are committed to engaging the private sector and external stakeholders as an essential component of really doing all of the things in these agency plans. But while the lead agencies will be monitored and held accountable for the actions they take to complete the objectives, we can only be successful if other people step up as well. So as we move forward, we'll also be increasingly looking to others for their leadership. And we really hope that when you look at all the exciting new things that the federal agencies are doing, it'll actually motivate others to make new commitments of their own. Because again, we can't be successful without other inputs. Now, I want to turn the page a little bit. I'm sure some of you on a day like today might have some questions about the president's budget, so I want to talk to that. So before we get to some of the HIV-specific provisions, though, I wanted to talk to you about how the president approached the development of his budget and what it means for our country's future. He believes that to win the future for America and our families, we have to out-educate, out-build, and out-innovate the world so we can grow our economy and create jobs. But we can't win the future if we pass on a mountain of debt to our children and grandchildren. That's why the president's proposed a 5-year spending freeze that will reduce the deficit by over $400 billion over the next decade and bring annual domestic spending to the lowest level since President Eisenhower. This is a responsible approach. It cuts wasteful spending and makes some tough choices on some things we can't afford while keeping investments we need to grow the economy and create jobs. We need to make sure that we're cutting waste and excess, not making across-the-board deep cuts in programs that are helping the economy grow and making a difference for families and businesses. Now, as we stated with the strategy itself, it should be used to refocus our efforts and deliver better results to the American people within current funding levels, as well as to highlight the need for new investments. The President's budget does both of these things. It refocuses our efforts, and it proposes targeted new investments. I'm happy to tell you that the administration maintains or increases domestic HIV/AIDS funding at HHS, HUD, VA, and the Department of Justice. Of the lead agencies I mentioned, not all of them have dedicated HIV funding, but all that do, we're at least maintaining funding levels or increasing. The budget increases domestic discretionary HIV funding at HHS by $219 million compared to fiscal year 2010, and it increases funding at the VA by $173 million compared to 2010, while maintaining HIV funding at HUD and DOJ. Now, I know many of you are anxious to hear about our proposal for the Ryan White HIV/AIDS program and the AIDS Drug Assistance Program, or ADAP. The current challenges facing many states financing their ADAP programs have multiple causes, from the economic downturn, which creates both challenges in financing state services, but also increases the number of people seeking to enroll ADAP as people lose employment. The pressure on ADAPs is compounded by our success at testing people more effectively identifying people living with HIV, as well as changes in clinical guidelines that call for an earlier initiation of treatment. Federal leadership is important to helping states weather this crisis, but we cannot do it alone. President Obama is committed to working with states, pharmaceutical companies, and other partners to ensure continued access to life-saving medications for people living with HIV. His budget will increase funding for the Ryan White HIV/AIDS program by $88 million over fiscal year 2010 for a total funding level of $2.4 billion. The budget increases funding for ADAP by $80 million over fiscal year 2010, which is really a $105 million increase over the enacted level at the beginning of 2010, prior to the transfer of $25 million in emergency resources. Within this total, the budget includes $60 million to continue a supplemental grants program to assist states' AIDS drug assistance programs with waiting lists that have implemented restrictive cost containment measures. Additionally, in recognition of the need to maintain access to critical early intervention and primary care services for people living with HIV, the budget proposes a $5 million increase in the Part C program over fiscal year 2010. People living with HIV should not have to live in fear that their access to life-saving medications could be taken away from them. By increasing funding by $105 million from early fiscal year 2010, when the waiting list for ADAP first appeared, the President is demonstrating a strong commitment to standing with people living with HIV and working with states and others to bridge the gap in access to HIV medications until insurance coverage is expanded in 2014 through the Affordable Care Act. Now I'd like to turn to some other agencies. So the budget will also support critical investments at CDC to prevent new HIV infections. The budget provides a total funding level of $858 million for HIV prevention at CDC, which represents a $58 million increase above 2010. Of this total, $30 million is allocated from the Prevention and Public Health Fund. The budget also transfers $40 million from the Chronic Disease Prevention and Health Promotion Program at CDC for school health programming to the National Center for HIV, STD, viral hepatitis, and TB prevention to achieve a closer coordination of CDC's HIV and STD programs. The budget includes an estimated $2.7 billion for domestic NIH HIV/AIDS research, an increase of approximately $70 million over fiscal year 2010, to support research priorities that will establish the scientific foundation to achieve the goals of the National HIV/AIDS strategy. Now, last year, or the last 14, 15 months, has really been a pretty remarkable time for HIV research. Some of our biggest advances have come in the area of prevention research, with exciting new results related to vaccines, microbicides, pre-exposure prophylaxis, and using treatment as prevention. NIH and CDC have been at the forefront of many of these advances. The budget will enable these agencies to help us seize the opportunities created by these new findings. At the VA, the budget includes $956 million in fiscal year 2012, an increase of $173 million above fiscal year 2010, and $70 million above fiscal year 2011 enacted for the Department of Veterans Affairs HIV/AIDS program. With this increase, the VA will intensify HIV screening efforts for all veterans, expand HIV testing and educational efforts, and continue to provide improved access to comprehensive clinical care, including life-saving HIV medications and mental health services. The budget includes $178 million for the Substance Abuse and Mental Health Services Administration, or SAMHSA, to continue its support of evidence-based prevention, interventions, and behavioral health services and treatment for people at risk for or living with HIV/AIDS who have co-occurring mental health or substance use disorders. And finally, the budget provides $335 million for the HOPWA program at HUD, which will continue to address the housing needs of persons living with HIV/AIDS by providing tenant-based rental assistance, operating subsidies for permanent and transitional housing facilities, and homeless prevention activities. Again, I'm certain I've given you just enough information to generate lots of questions. So over the coming days, the departments will be rolling out their own budgets, and this will create opportunities for you to dig in a little deeper into the details of the agency's plans. Additionally, as in the past, leaders of the operating divisions and other senior HIV leaders across the government will be briefing the Congress on elements of the President's budget, and this will also create opportunities for you to learn more. The President is putting forward a responsible budget to enable the nation to win the future. He's also putting forward a budget that clearly demonstrates his determination to help the nation achieve the goals of the National HIV/AIDS strategy. So far, I've only told you about the parts of the President's budget related to the money. And while the levels of investments are important, equally important are the steps that we're taking to ensure that the public's investments are having a maximal impact. It's now my pleasure to introduce the Assistant Secretary for Health, who is going to talk about some of the very significant policy proposals in the budget, as well as the very important work that HHS has undertaken since July to implement this strategy. Dr. Koh?
Thank you so much, Mr. Crowley, for that nice introduction and for your just absolutely tremendous national leadership. I think Jeff Crowley deserves another round of applause here. And I couldn't think of a better way to spend Valentine's Day than with everyone here talking about the operational plan for the National HIV/AIDS strategy, because it warms all of our hearts, literally, to show that we are serious about making progress on this challenge. And we are talking about a very hopeful future now that's becoming real to us by the minute. We've had phenomenal leadership by the President, and it was a joy to see so many of you at the White House last July when he personally unveiled the strategy. And it's been an absolute privilege for all of us and for me personally to work so closely with many of you to make that strategy come alive. Let me say right at the beginning that, again, I want to acknowledge our partners from our federal agencies who stood up a little while ago. You are all heroes to me. You've attended so many meetings, shown your commitment. I want to thank you, again, from the bottom of my heart. Round of applause for our partner federal agencies. Thank you. And I want to give a special public thanks to my incredibly dedicated colleague, Dr. Ron Baldessari, our Deputy Assistant Secretary for Health. Ron, can you stand up and get a round of applause? We have a strategy now that honors the past, learns from the past, but really gives us hope and a commitment for the future. So Mr. Crowley has asked me to just give you some more details about the plans about moving forward. And let me start by saying that we could not have done this without consulting with everybody here, the community leaders who are gathered here in this room, and then hundreds of others across the country. And we've been in many, many, many meetings since last July to listen to you, to hear your expertise, to get your advice, and to help shape this operational plan that we are releasing today. I was just reflecting that only a number of months ago, I had not met so many of you. Now you are literally members of my extended family on Valentine's Day. We gathered at the International AIDS Conference in Vienna in July. We had a meeting of women leaders hosted by our Office of Women's Health in September. We met at the U.S. Conference on AIDS in Florida in September. We had several web conferences hosted by the Coalition for a National HIV/AIDS Strategy. We had a number of consultations with our Presidential Advisory Council for HIV/AIDS, PACHA, a community check-in meeting sponsored by our office and led by Dr. Valdesari. We've met with state and local health departments, with advocates, with researchers, with prevention and care organizations, and all of you had tremendous suggestions about how to make this strategy really come alive and make it effective and one that's going to make a difference. Just about all of you steered us toward this first step of really rallying around this 12 cities initiative. You know that the 12 jurisdictions that we've identified represent some 44% of the people in the U.S. living with HIV or AIDS. This was anchored in a strategy launched by the CDC's Enhanced Comprehensive HIV Prevention Planning Program. It was initially funded at a level of $11.6 million in fiscal year 2010 and 2011. We are very grateful that for fiscal year 2012, that program funding will increase by some $10 million for a grand total of close to $22 million. And that provides a framework for really tackling together collectively an approach that will make this strategy come alive in these cities of highest burden. In fact, the 12 Cities Initiative is in many ways a microcosm of the strategy itself. And we are so grateful to many of you who helped shape the strategy in collaboration with the CDC, brought it to our attention, and we are ready to embrace this and make this come alive. I also want to stress that our Secretary, Kathleen Sebelius, is fully engaged and fully supportive and fully enthusiastic about making this strategy a reality. She has met with Dr. Valdesari and me a number of times. She has met with community leaders a number of times. And just last month, she sent out a memo that recommended that the leaders of our department, Health and Human Services, actively support the 12 Cities Project, streamline grant administration, and streamline grantee reporting requirements so that there's one set of reporting requirements for agencies that are funded. She sent a very strong message about enhancing coordination and collaboration across HHS so that our goals within the department are consistent with the strategy goals. She's asked our Office of the Assistant Secretary for Health to do a technical review of all future funding announcements coming out of Health and Human Services so that we are indeed one department that serves the community in a coordinated way. And she's asked for a very comprehensive review on all the budgets from all the operating divisions and staff divisions of Health and Human Services to make sure that those activities align with the priorities of the strategy. She and also the Deputy Secretary, Bill Corr, have been very supportive of a cross-departmental working group that has been led by Dr. Valdesari and myself. It has senior representation from CDC, HRSA, NIH, SAMHSA, the Indian Health Service. Our entire group has met several times. We brought in leaders from the outside to be as transparent as possible and to get your advice. And we are eager to have this group move forward to make this operational plan come alive. We're also looking now very seriously at our funding formulas within our various agencies to see if we can get more consistency. And as you heard from Mr. Crowley, we've also had great leadership with respect to coordinating funding formulas for housing opportunities for people with AIDS as well. Throughout all these efforts, it was my great pleasure to convene a number of our federal partners from the other lead agencies. I've been impressed with your commitment and your concern and your real desire to make this a one government effort that helps one country and makes this one community as we move forward to make the goals of the strategy truly come alive. Just to show you how serious we are at the department, how serious the Secretary is, the 2012 budget now authorizes the Secretary of Health and Human Services to designate 1% of domestic discretionary HIV/AIDS funding to support this new collaboration and coordination at the highest level. And so we are eager to use these funds to address the issues that you have brought to our attention. interventions for high-risk and underserved population, improving linkages to care, tracking outcomes, and making sure that we are reaching goals of the strategy as soon as possible. So those are major, major themes of our operational plan moving forward. Another major point of our operational plan is that we know that reducing disparities is one of the overarching goals of the whole strategy. We are committed to refocusing our minority HIV/AIDS initiative, the so-called MAI funding. Many of you are very familiar with the MAI funds. Right now, there's set-aside funding at HHS for the operating divisions at a level of some $400 million. The Secretary's portion of this, some $54 million, is going to be re-examined with particular leadership from Dr. Valdesari and myself, and we want to commit to using those Secretary funds to really make HHS work as one department in achieving the goals of the strategy. We want to make special efforts to focus on reducing the high rates of infection among women of color, among Black and Latino gay youth. We want to keep supporting the efforts of the Indian Health Service, and these are some of the themes that you're going to hear as we look into shifting and refocusing how these MAI funds, from the Secretary's point of view, will be used in the future. A third theme you heard from Mr. Crowley is shifting prevention resources from low to high impact activities. The CDC, in their new budget, will be redirecting over $50 million to do exactly that, to better link and maintain people to care, to enhance adherence to antiretroviral treatment. And we are going to be, and the CDC will be, de-emphasizing some of the attention in the past to intensive individual and small group interventions, which were valuable, but didn't have the broad population impact that we are now seeking. And then again, I want to thank our federal partners. In the last meeting we had a lot of attention, particularly to the housing issues of people with HIV and AIDS. That's one cross-cutting issue that's going to bind us together as we move forward, and there will be other cross-cutting issues among these 6 lead agencies as we make this operational plan come alive. As I close, I can't help but think that it was some 30 years ago that HIV/AIDS was first described in this country. At the time, I was a young physician in training. I like to think I still am a young physician, not in training. But we have all collectively seen an incredible trajectory with respect to the epidemic in this country. We now have an opportunity to truly make a difference. Everybody in this room and hundreds of others have brought us to this remarkable point. Again, I want to thank the President, Mr. Crowley, but especially everyone here, everyone who cares passionately about this issue, to make sure that we continue to make aggressive progress so that we indeed achieve the goal and the vision of the strategy, that is to make HIV rare and to make sure that every person gets the care that they need and deserve. Thank you very, very much.
We'd like to now take a few questions from the audience, if anyone has a question. Carl?
Hi, thank you very much, Carl Schmidt at the AIDS Institute. We really appreciate the attention that you have provided, and the President, the leadership, and the increases for ADAP program particularly, and for prevention at CDC, although we know it's not enough, but we know the times we live in. But my question is this 1% of the discretionary funding that could go for them to carry out the National AIDS Strategy. I saw that in the CDC budget, they said they're counting on sending that 1% to HHS. And so I guess my question is, how is that going to be determined, and what things that could be spent for? Does the CDC portion have to go for prevention things? Does the Ryan White ones have to go to care and treatment, or could there be mixing of the funds?
Well, we haven't even begun to address any of those specifics yet, and of course, we need the budget all passed in FY12 before we can even start in. But we want those new collective resources to really make the strategy come alive. That's the goal, and we're going to have leadership from our coordinating committee that has been led so nicely by Dr. Baldessari weigh in on the best use of those funds to make the strategy helpful. Again, we want efforts like that to achieve outcomes that we could not do separately, but now will be possible since we are working together and with opportunities like that.
Thank you. Another question?
Good afternoon, Donna Cruz from Edge United. A question about the E-CHIP program. In the HHS budget that was released, it said an increase of $10 million. In some of the other documents talking about the overall HIV program, it talks about $22 million. And Jeff, you mentioned $30 million from the Prevention and Public Health Fund. So a two-part question: is the $12 million of the 22, is that going to be redirected funds from CDC? And secondly, since you're talking about prevention and wellness for FY12, why was it not included in FY11 prevention and wellness?
Sure. So, the President announced the $30 million allocation for FY10 when we released the strategy, and the single biggest component was what we're now calling E-CHIP, the Enhanced Comprehensive HIV Prevention Plan. We allocated $11.6 million in 2010. He also said at the time that he was committed to ensuring that those funds continued. There was a legislative process that took place right after we released the strategy, and quite frankly, there were some questions of whether we would lose some discretion allocating the funds. And because he was so committed to ensuring those funds continued, in August we put forward a budget-neutral budget amendment. So we found offsetting savings and put forward a budget amendment to increase our FY11 CDC prevention funding in our discretionary budget by $35 million to ensure that the full range of those prevention fund investments continued. Going forward in 2012, we are again allocating money from the prevention fund for HIV prevention. Now, as we think about the totals in a number of these issues, some of the funding comes from the discretionary budget, some from the prevention fund. I can't, off the top of my head, give you the allocation, but my belief is that specifically for the E-CHIP, that we're funding $11.6 million out of the CDC discretionary budget, and then $10 million that increased through the prevention fund.
Ernest.
Ernest Hopkins, San Francisco AIDS Foundation. Just want to thank you very much for convening today to give us an opportunity to ask you a few questions about the operational plans and the budget. With regard to the comments that you just made, Dr. Koh, about de-emphasizing the individual and group-based interventions, I would like to get a little bit more clarification on exactly how that's going to be operationalized at the CDC. One of the challenges that we have identified as we go across the country looking at communities and trying to get them prepared to implement the Affordable Care Act is the fact that much of our community-based infrastructure is very challenged by the fact that we're sort of having state and local budget cuts at the exact same time as we face potentially flat funding at the federal level. And maintaining those infrastructures of small community-based organizations that actually have access to the populations in need is going to require some significant support on the federal side. Many of those institutions also are disproportionately providing that kind of intervention in our communities. And so I guess my question is, as we shift away from individual and group level interventions and move to interventions that have a broader impact on community, on the community's epidemics, what is the effort that the HHS will be taking in order to ensure that the infrastructure that we will need going forward with the Affordable Care Act is sustained, and that the kind of technical expertise that these institutions will require to implement a different kind of intervention is available to them?
Sure, thank you. And first of all, I want to thank Mr. Hopkins for, he's been so passionate, so insightful and helpful, and many of the ideas I just reviewed came from you. So thank you, Ernest, for all your support. I think the answer to what you're raising comes in the next steps of the 12 Cities project. Exactly how do we do community planning? How do we make sure that we have federal, state, local, and community partners at the table as that community planning process moves forward. That's why the next number of weeks and months for this 12 Cities project, I think, is very, very important. We want it to be a process that's supported by these 12 cities. We want it to be one that everyone believes moves the goals of the strategy forward. We believe we can do that with this new emphasis on coordination and streamlining reporting and common metrics and those sorts of themes. So we will obviously be very sensitive to the issues you raised and be very respectful to the communities we serve as we move that planning process forward. And there are many people in the room who have conveyed to us that we are very hopeful that we can make this 12 Cities project work and then move on and tackle the rest of the country in a very short period of time.
I'd also like to add that I encourage you to read the supplementary materials from the CDC and their congressional justification. So one of the things I would say is that, in responding to HIV with any community, we've got to be narrowly focused on the things that are most effective. We invest money in communities. So first we, give money to communities. They go through a community planning process, look at what their epidemics look like, and look for the populations that should be targeted. We need to always make sure whatever population we're targeting, we're funding the investment, the interventions that we think are most effective. In the CDC's justification, they give some examples, not fully comprehensive, of some of the things that they think are more effective and we should be scaling up, some of the things we should be de-emphasizing. It's not saying you could never do this intervention again, but de-emphasizing. But some of the clear directions they are talking about going in is a greater emphasis on prevention with positives, increasing linkages to care, increasing adherence supports, behavioral risk reductions for HIV positive individuals is kind of a direction. I think that could be useful. But as we think about doing all of those things, in no community should we think that that means an organization that's been funded, even if it's being funded for an intervention that we would be de-emphasizing, that doesn't mean their role would have to go away in serving those populations.
Anna? You have to meet me halfway.
Hi, thank you both so much. Anna Ford with UCHAPS. I just have a follow-up question, actually, to Don. I was hoping for some more clarification on ECHIP in 2011 and 2012. We are aware that the President amended his budget request for 2011 to put an additional $30 million, which would cover the ECHIP program. And as we now have seen, the Prevention and Public Health Fund did not continue its investment in HIV prevention for 2011. But in reality, as we see what's unfolding with the appropriations process and the cuts that CDC is facing, it is unlikely that CDC will see an increase of that amount that the President proposed in his budget. So is it your expectation that ECHIP will continue in 2011 and 2012 at $11.6 million, the investment from CDC's discretionary funds at the expense of other CDC programs, and if so, which ones? It's just some further clarification. I understand your response to Donna's question, but what does that mean for 2011?
I think, quite frankly, you might be seeking some certainty that I can't provide you. We're going through a legislative process to get the budget. What I can tell you what our priorities are. As I told you, we consider ECHIP a priority, and we consider it a priority to fund at the level of 10 for FY11 going forward. There will be a legislative process going forward to give us a budget for the remainder of the year. I can't really foreshadow what's going to happen. It's premature to talk about any of those contingencies because we just don't know. But I can tell you that this administration sees the ECHIP program as a priority new program, and we intend to support it.
2 more questions.
Hi, Deborah Hickman from Sisters Together in Reaching in Baltimore, Maryland. And my questions actually are in reference to questions that we developed in Baltimore City together. And specifically, I think it relates to what Carl Schmidt and Ernest spoke to earlier in terms of how will you encourage the federal agencies to continue to work on interagency coordination to maximize limited resources and to make certain that the jurisdictions are getting the technical assistance that they need, and how do we go about merging data or sharing data across jurisdictions to make sure that we are effectively maximizing the programs that we are funded to do? And can you also minimize the grant requirements of how the community-based organizations as well as the states are able to, the the grants actually seem complicated. So can you make certain that they are less complicated so that we write the best possible grants that we can?
I mean, I'll let Dr. Coe answer. The first thing I'd say, though, is I think he opened his remarks and said that, you know, the work that they're doing forward is looking at some of this grantee simplification. But a lot of the questions you ask is really why we have the ECHIP program and the 12 Cities Initiative. We have ideas about doing integrated planning, and we're using these 12 cities as a models of innovation. Some of them will encounter more challenges than others, but hopefully by working through these in these jurisdictions, we can learn lessons that we apply across the country. And that's really why we're so excited about this initiative.
So thank you for your comment. And again, when we interacted with community leaders and community advocates, we heard repeatedly, why can't you and government work together as one government? And because the sense that was reflected back to us was it was too disjointed and not coordinated enough. So this is why I'm very, very pleased that our secretary has put forward in writing a directive to us at the department to really, first of all, back the 12 cities pilot and make that a reality, so then we can then move on to the rest of the country, to really move into a common set of metrics for the grantees, to really have a unified review of funding announcements by our office, by Dr. Valdesari and his office moving forward, to really unify reporting requirements on grantees so that they're not spending a lot of time giving information to various parts of government when they could really spend their time more efficiently. And so we think these are really excellent first steps. And then as we presented these themes to our federal partners, they resonated with them as well. So we are steadily moving toward trying to be one government that serves the community in a unified way. And so we're very hopeful that the community will feel a difference very, very soon.
Thanks. Nancy Mann from MAC Cosmetics. First of all, thank you for working so hard. I think we all appreciate in a flat funding environment that you guys have really found money under rocks, and that particularly on Valentine's Day, partnerships and collaborations are hard work. But one thing I wanted to ask, I'm sure many of us would move certain numbers around from one column to another, but I think we all agree that we fully support these dollars for AIDS. And so I'm not asking for a partisan response, but what can we in the room do to best ensure that these funds are in fact passed by Congress?
You know, as we've said all along, that, you know, the American people have provided strong support for the HIV epidemic for going on 30 years. You know, we're at a level of more than $21 billion in support for the domestic HIV epidemic. To continue that, we need to show that we're doing the hard work of ensuring that everything we're investing in, we believe it has an evidence base for why it's effective, but also making tough choices and moving away from some of the things that don't work. I think what you can do to help is help tell that story, that we are being strategic, you know, and that the American people can accept good outcomes from the investments we're making. That even in these tough times, you know, there are benefits for the individuals themselves and communities for doing everything we can to prevent HIV and fully support people living with HIV. So part of it's just telling that story, because we do have a good story to tell. We've come a long ways in 30 years, you know, from the research advances, how we've responded as a country, and we need to make sure that whether it's policymakers in Congress or people across the country that are really worried about have we overextended ourselves, understand why these investments are important.